I'm saying that to him.
Yeah, okay.
Hello. Hello. Yeah, sir. We are live now. You can start by introducing yourself. Yes. Are the slides visible
Hello.
to you?
Hello.
Hello. Yes, sir. Are the slides visible to you? Hello. Sir, you're on mute. Hello. Yes, sir. Are the slides visible to you?
Hello.
Hello. Yeah. Is the slide visible to you? So you can start the
Hello.
session. Hello. 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 Hello.
Hello. Hello.
Hello. Hello. Hello.
Hello.
Hello. Yes, sir. Am I audible to you?
Hello.
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 Hello, sir.
There is some problem.
Start. The session is live.
No, I agree with you, but there's no. It's not audible at all. I'm not able to hear anything from Saurabh.
So that
Hello.
must be Saurav is saying that he was not able to hear you.
Yeah, what is the problem?
Yes, sir. Can you please start?
No, I have started, but he has to control it. Now he has loaded it, but if I start, it is not audible.
Okay, sir. Actually, Saurav was not able to hear you as well.
No, that is why I'm asking what is the problem, because
Hello,
I'm
yeah, sir, you are
unmuted.
audible to me now.
Then video is on, but I'm not. So because whatever I say, Saurabh should talk to me.
Yes, sir. I am getting your point, but I am not able to understand what is the technical problem is happening.
Now you see, basic problem is that I have sent a slide to him. I don't have the latest version of the Zoom,
Yes, yes.
so therefore it is not taking my presentation, and it is not opening up. So therefore, last time what you did was you took my presentation and you were controlling from your end. I was just, and we were in communication by audio. We were not directly seeing. Yeah. And now same thing I have done. I have sent my presentation to him, and he has loaded my presentation, but there is no audio connection. There is no audio connection.
Hello.
So
Yeah, sir, am I
he has
audible
to
to you?
actually do the,
I'm just
yeah.
yes, sir. Sir, can you please unmute and mute? Can you please mute and unmute it again?
Yeah, I will do that again. There's no, it is now. Yeah, again I will do that. No issue. Now,
Hello. Sir, you're on mute.
tuberculosis. And with the HIV, the tuberculosis epidemic became quite rampant in the 90s, especially in Africa and Asian countries. And today we have 13% of HIV who have tuberculosis, with 0.36 million, that is 3.6 lakh people dying due to HIV and TB, and 78% of them are from Africa. So we have more than 500 cases per 1 lakh population per year, and there's a decline in the percentage by 2% each year. Now, after the initial increase in the number of cases due to HIV and drug resistant, due to effective measures in treating tuberculosis, there has been stabilization and there is decline in the annual incidence of the disease from 2013, giving a hope that we can eliminate the TB by NTB, not elimination, by 2025, and then we can eliminate the TB by 2050. That means when you have only 10 cases, uh, one cases per 1 million population, it amounts to elimination of TB. And today we have a figure of 400 to 500 per lakh population. Next slide, please. And TB, we have different types of TB. One, we have TB infection, a TB is a disease, and we have non-tubercular mycobacterial diseases that do not come under the classical disease caused by Mycobacterium tuberculosis. Next slide, please. Now, when we look at the Mycobacterium tuberculosis complex, we have different types of Mycobacterium tuberculosis complex. It includes the classical Mycobacterium tuberculosis, Mycobacterium bovis, caprinae, africanum, microti, what is called the Mycobacterium whorl, and then we have Mycobacterium pedi, that is common in seas and sea lions. Then we have Mycobacterium mungii, that is common in mongooses, and we have Mycobacterium oryzus, that is common in variceps or bovidae, and we have Mycobacterium kennet, that is common in East Africa. They produce smooth colonies. But the most important one is the Mycobacterium tuberculosis, that is responsible for most of the cases of tuberculosis. And when we look at the under the microscope of the Mycobacterium tuberculosis, it's a rod-shaped bacillus and a size of 0.5 to 0.3 micrometer, and it is acid fast. That means it cannot be decolorized due to high mycolic acid content in the cell wall. And we have certain mycobacteria or certain bacteria which are also acid fast, and they include the rhodococcus, nocardia, legionella, mysidae, isopsora, cryptosporidium. Though the isospora and cryptosporidium are the fungi, and then we have legionella is a type of bacteria, and we have nocardia, and we have rhodococcus. They are also acid fast. The Mycobacterium tuberculosis has a typical rod-shaped appearance, and then it is acid fast. And by genomic sequence of the mycobacteria has revealed that it has got 4,043 genes and 3,093 encoding for the proteins and 50 for the RNAs. So they encode most of the genes encoding for the proteins of the tuberculosis proteins and 50 for the RNAs. Next slide, please. Now, tuberculosis is an airborne disease. It's an infectious disease, and it is caused by Mycobacterium tuberculosis, the commonest one. And I have already told you that there are different types, and majority of them are caused by Mycobacterium tuberculosis. And non-Mycobacterial tuberculosis are caused by more than 200 species that ubiquitous, that environmental mycobacteria, they're present in the water, they are present in the soil, and out of which minority of them are due to Mycobacterium avium and Mycobacterium abscessus, Mycobacterium consortii, and they cause pulmonary as well as extracellular tuberculosis. But TB, as you know, is an airborne disease. Next slide, please. Next slide. Hello. Next slide, please.
Yes, sir. Which one? The transmission one?
Yeah. Now, the transmission is by droplet infection, and each cough produces around 3,000 nuclei droplets. These tiny droplets suspend in the air, reaches the alveoli, and they deposit in the upper airways, lower airways, and some of them reaches the alveoli, where they attach themselves to the dendritic cells and also the alveolar macrophages. And it's a cavitary tuberculosis and the laryngeal tuberculosis that are the most infectious. And they produce 10 to the power of 10 of bacilli per ml of sputum. So, an individual with the sputum positivity has already infected 20 people before the diagnosis is established. It is highly infectious. Those who have high frequency of cough, those who have a cavitary disease, who have a laryngeal tuberculosis, they are highly infectious. Now, one third of the world population are infected. The 40% in Indian setting, maybe around 25 to 30% in the Western setting, they're infected. And this infection doesn't mean that they have a disease, they have a latent TB. The risk of infection to disease depends upon the body immunity, which is innate immunological and non-immunological defenses, and the level of the cell-mediated function, mediated immunity function. Those who have diabetes, who have organ transplantation, immunosuppressive therapy, those who have HIV. So these are the patients who are more prone for reactivation or the progression of the primary infection. The primary TB disease is the one which soon the clinical features of tuberculosis. Soon after the primary infection is a primary TB. The secondary occurs after the primary infection, and after primary infection, the infection is contained by the body defenses, and 10% of them, otherwise healthy, develop a post-primary infection and reactivation in a lifetime. And this becomes much higher, even up to 100%, if a person has got HIV or suppressive disorders. Otherwise, a normal individual who has been infected and is tuberculin positive has a risk of developing active TB to the extent of about 10% in the entire lifetime. And most of this TB occurs in the late adolescent phase and the early childhood phase. And in women, it is between 25 to 34 years of age, and old age also can reactivate the disease. Next slide, please. So, what is the natural cause of the disease? There's an exposure. The person coughs, an infectious case, one gets exposed, and then they go to the alveoli. Then the body immune responses come in, and they can have a subclinical infection. Some of them they can progress and they develop an active TB, becomes an infectious tuberculosis. And if its sputum is negative and the transmission is not possible, then it is a non-infectious tuberculosis. And if you don't treat them, or if they develop complications, and some of these cases may die. So this is the natural cause of the disease. Next slide, please. Now, what is the fundamental pathophysiology? Now, if you don't treat, 1/3 of the patient die within 1 year, 50% before 5 years, the mortality is about 65% at the end of 5 years. Survivors at 5 years, spontaneous recovery with remaining excretive bacilli. They are contained. So if a person survives at the end of 5 years, yes, the infection is contained, but is a source of infection to others because still they have active bacillus and they are being excreted in the sputum. It is out of this inhaled vessels, only 10% reach because some of them they get filtered in the upper airways and the lower airways. There's only 10% of them they reach to alveolar macrophages. They are phagocytized by the macrophages, and the bacillus survives inside the macrophages. And because it's less acidic, and the bacilli multiply, and macrophages rupture, other macrophages get infected, and so that is how the infection, and then there is activation of the body defenses to various mycobacterial antigens, and the macrophages therefore releases TNF, and also dendritic cells uh, present them to the T cells, and which are draining to lymph nodes. So we got two types of response. Next slide, please. Next, yeah. So the disease, they get ingested by macrophages, they survive, they continue multiplication. The inflammatory response brings more defenses, cells to the area. Alveolar wall damaged by cytokines, and then there is activation of the lymphocytes and also monocytes, deactivated macrophages. They all accumulate and they form what is called the granuloma. There are two types of reaction which can occur. One is a delayed hypersensitivity, where there is tissue necrosis or caseous necrosis, because there is lysis of these macrophages, and then we have activated macrophages, which form the granuloma. The activated macrophages release various cytokines, which try to destroy the bacilli, whereas the delayed hypersensitivity response is one where the macrophages are killed by the mycobacterium itself, and so the non-activated macrophages they get lysed and they contain multiplying mycobacteria. Next slide, please. So it is a T lymphocyte release various cytokines, activate macrophages, which kill bacteria. Few where the macrophages CMI is weak. The delayed hypersensitivity operates to cause lung destruction, the destruction of the non-activated macrophages, which has got multiplying TB bacillus. The TB bacillus escape and it tries to spread. So we have CD4 cells which produce type 1 response, interferon gamma to activate the monocytes and macrophages, while T2 response causes humoral immunity to interleukin 4, 5, 10, and 13. CD8 cells cause cytotoxic response and lysis of the infected cells, that is, delayed hypersensitivity reaction, and production cytokines, interferon, and TNF. So then we have antibodies which can be produced to lipoarabinomannan, which are present, which are the proteins which are present in cell wall, and then the tuberculosis skin test becomes positive when we have developed the cell immunity, and that occurs at about 6 to 8 weeks after the primary infection. And when you actually introduce it subcutaneously, and that is where the CD4 cells migrate there, and then they release cytokines, and there's a local reaction, and that produces what we call the tuberculosis positive reaction. So this also offers, to some extent, a partial immunity. Next slide, please. Now, I've already told you there are two types of response: tissue damaging response, where the whole macrophage is lysed, and then macrophage activation, that is by CMI, and then they kill the multiplying mycobacteria inside the cell. Next slide, please. Now, so we have three options. One, we have latent TB infection. There is no disease. We have one healed focus may be found, and there is no activity. Then the tubercular bacillus spreads. Then two types of response occurs. As a result, we have a granuloma formation and caseation, a lung destruction. So it produces a fibrocavitary tuberculosis. Sometimes the body may not produce a typical response, and when the immunity may be low, or you may have a small multiple granulomas of the size of the millet seed. So there is a widespread dissemination can occur, what we call a disseminated tuberculosis, which classically presents in the lung as miliary tuberculosis. In the tissues, you may find the miliary nodules microscopically. They are of the size of 0.5 to 2 millimeter, resembling the millet seed. Next slide, please. Next slide, please. Latent TB is a condition where there's a persistent immune response without active disease. And individuals with latent TB are at a high risk of developing infectious TB. Next slide, please. Next slide, please. Now, the fundamental difference between latent TB and pulmonary TB. Now, in the latent TB, that is interferon gamma releasing assay. That means if you stimulate the T lymphocytes by tubercular antigen, they release uh, uh, gamma interferon. Okay, so that is in vitro test. Other is we have TST, that is tuberculin skin test, where we introduce PPD, is introduced subcutaneously, 10 units of PPD is introduced. Then we see the reaction, and if the reaction is more than 10 millimeter with induration and with hyperemia, so erythema, then we call it as a positive tuberculin test. So they have a positive IGRA or a positive tuberculin test, and they have a negative chest X-ray. They don't have any symptoms. They are the latent TB. Whereas in case of pulmonary tuberculosis active, we have a positive MANTU or the tuberculin skin and we have a positive chest X-ray shows abnormality. They have symptoms of fever, cough, night sweats, weight loss, fatigue, hemoptysis, loss of appetite, and there is pretty specimen. Maybe smear positive in culture, depending upon the number of bacillus they excrete and which are present in the sputum. Next slide, please. Now, latent TB, there has been a lot of emphasis on latent TB. If you want to eradicate TB from the globe, then we have to eliminate the latent TB. Now, because latent TB is the potential source of epidemics, is a potential source of the sudden outbreak of TB. And so, in Western countries where the TB, latent TB incidence is low, they try to eliminate the latent TB by chemoprophylaxis. Because the infection as such is not, the environmental pool of infectious disease is much less. And so, if you want to eradicate TB, then the first step is actually treat latent TB, detect and treat latent TB. And in 1987, we had 1.86 billion cases. And with effective chemotherapy, and also because of environmental control, the, the number of TB, latent TB, have come down to 1.7 billion cases. And still, as I told you, it is still a global prevalence of about 23 to 25%. And in India, it is about 40%. And those who have immunosuppressive state with the latent TB, they have a higher chances of developing active tuberculosis, both pulmonary as well as extrapulmonary. Next slide, please. So we have a high risk group. Next slide, please. And this high risk group, the persons with HIV, the adults who come in contact with tuberculosis, they don't have a native immunity and they come in contact with tuberculosis and they can develop active TB. Patients receiving tumor necrosis factors, patient undergoing hemodialysis, patient undergoing organ transplantation, patient with silicosis, prisoners, those on mental asylum, healthcare workers because of they're constantly exposed to the infection, the high and infectious zone, then immigrants from the countries with a high tuberculosis burden, homeless persons, illicit drug users, elderly patients. They are the ones who have the highest risk of developing active tuberculosis if they are found to be tuberculosis positive or who have latent TB. Next slide, please. Next slide, please. So that we have to, how do you make a diagnosis? We have to have a high index of suspicion. Chest X-ray may be typical or may be atypical. Primary setting, AFB smear and expert TB, and it should be done at secondary level. We can go in for the ZN staining, rhodamine, auramine, fluorescent staining using mercury lamp, vapor lamp, which is somewhat costly, and now it has been replaced by LED, that is low emitting diodes light, which is much cheaper. So you can actually diagnose tuberculosis by classical Zeal-Nielsen staining, and you can also do the fluorescent staining, which can detect large number of bacillus in a short time. And LED has replaced the uh, the classical mercury lamp vapors. Now that is fluorescent microscopy. The and in those cases who have culture positivity, in such cases the smear may be sensitive in only about 40 to 60%. Now we have to examine the three specimens, and what has made a revolutionary change is the automated real PCR expert MTB refreshing, which detects less than 2 hours, which has got a 98%, almost 98% sensitivity, and and then who are sputum, otherwise culture positive, and about 70% who are culture negative, AV negative specimens. So what I want to tell you, the automated real PCR expert MTB has made a difference in the global detection of the tuberculosis, and it can actually detect the tuberculosis to a great extent about a sensitivity ranging from 85 to 98% and specificity around 95 to 99%. And especially if the person has got AFP positive, and those are AFP negative, in those cases, the sensitivity is lower. Then we have classical MTP cultures, which I use the LJ media, and, uh, and so it takes about 8 weeks. It produces rough, buff, tough colonies. That is a classical, the description of the colonies of the mycobacteria, which have been incubated in the LJ media. The specimens have been incubated in the LJ media, and so then it takes about 8 weeks. But if you actually do liquid cultures, you can detect by about 3 weeks time, and then we can do a lot of molecular techniques to detect both drug sensitivity as well as drug resistant bacillus, and we can actually test for the first line as well as the second line ATT drugs. So they actually, by molecular sequencing technology, we are able to actually identify the specific genes of the bacteria, mycobacteria, which are resistant or which are sensitive to the particular drug. So in we have agar-based medias, that is uh, LG media, Middlebrook media, 7H10. So then here we used to do earlier biochemical tests. Those tests are no longer being produced because we have better molecular technology to detect the drug resistant and mycobacteria and sensitive mycobacteria, and also to identify atypical mycobacteria. Liquid culture for isolation, that is MDIT, detect oxygen by fluorescent technology, and the species identification by immunochromatographic assay for detecting MTB64 antigen, and to detect it detects in 2 to 3 weeks. Rapid detection of MDR by RPOG and CATG extract DNA, amplify, and detect the resistant genes by PCR and calorimetry. So what I want to tell you that by using MG80, by liquid culture, and by applying these molecular diagnostic techniques to identify the drug resistant as well as sensitive uh, mycobacteria, we are able to make an early diagnosis. Next slide, please. Next slide, please. Next slide, please. So there are certain limitations of uh, the AFB smear, and uh, so it involves the processing, digestion, decontamination, concentration of primary patients prior to setting of a culture. That you see, only 43% primary tuberculosis was sputum smear positive, and the rest we may not be actually detected by classical AFB smear examination. Next slide, please. Next slide, please. So it does not distinguish between viable and dead organisms, and there is a limited sensitivity. So high bacterial load should be that at least 5,000 to 10,000 AFB in ml is required for detection. So it has a limited specificity, and all mycobacteria are acid fast. So therefore, does not provide a species identification. Next slide, please. Next slide. So next slide, please.
Sir, I've
Next
changed
slide.
to direct smear.
Next. Next slide, please. Next slide, please. As I told you, the AFB are 1 to 10 micrometer, 1 to 5, 1 to 10, whatever you say, 0.2 to 0.6 in width. So it is a bacilli, and it is long, slender, but may also be bent, beaded appearance, may contain heavily stained areas like called the beads. So the count, there could be clumps of bacilli, and some of the debris, some species like Nocardia, Corynebacterium, and others, which I told you, Isospora, etc., Rhodococcus, they can be acid fast. Next slide, please. So the sputum, of course, is the classical source. Otherwise, sometimes you may have to take the specimen to bronchoscopy, induce sputum, and sometimes you have to take the tissue by bronchial biopsy or transbronchial biopsies, or by EBUS, the lymph node biopsies. So to the specimen containing the AFB. The serology has a poor sensitivity and specificity, and it is not recommended by WHO. TB skin test, which uses the word tuberculin, which was introduced in 1891. In 1932, Siebert and Munday purified by ammonium phosphate precipitation to produce PPD, purified protein derivative, and PPDS was discovered in 1941, and it is an international standard. And WHO UNICEF came out with PPD 23, which is used nowadays. So it lacks the microbacterial sensitivity. So it only detects the T cell response to TB. And repeated cervical testing can give you a booster phenomenon. BCG vaccination can give a booster phenomenon. So sometimes it's very difficult to say whether it's an active disease or a latent TB. So then interferon gamma releases IGRA. The T cells are stimulated by ESOT6 antigen, CEP10 antigen, and also antigen 7. No, not antigen 7. It is only two antigens, CEP10 and ESOT6, that is in the TB spot test, and gold ferron interferon gold test we have three antigens, ESR16, antigen CEP10, and antigen 7. So they are the one, they actually stimulate the T cells, and as a result of which there is release of gamma interferon, and which is actually detected by ELISA. And it is not able to diagnose active TB and use in children over 5 and below 5, we prefer to do TST, tuberculosis skin testing, sensitivity testing. Next, next slide, please. Next slide, please. Next slide. So, the tuberculosis skin test versus IGRA. Now, here in TST, tuberculosis sensitivity, 2 visits are required. First, you inject, then after 48 hours to 72 hours, again you look at the induration and erythema. And BCG may interfere with the results. NTB, NTM, non-tubercle microbacterium may interfere. So, subject to result, 2 different readers, there could be variation. We have 2 answers. Situation dependent cutoff. Some say 5 millimeter, some say 10 millimeter, some say 15 millimeter. 5 millimeter if you are HIV positive, 10 millimeter is a standard, and 15 millimeter there could be higher reaction, maybe suggestive of some active TB as well. Now, whereas IGRA, we take 3 cc of blood, 1 visit, 1, and the job is done. No BCG interference. Most NTMs do not interfere. That means atypical mycobacteria do not give a positive IGRA. It is objective, reproducible results, highest specificity, but the cost factor is there, and we cannot employ as a mass screening method. Next slide, please. Now, latent TB approach, as you know, that we have to differentiate whether they have active TB or it is a latent TB. Active TB means they have symptoms, radiologically they are positive, and then if they are active TB, then the treatment is different. If it is LTB, latent TB, in such cases, we may just observe. In developed countries, they go in for the chemotherapy. Next slide, please. Next slide, please. Now, there is one terminology called the primary infection. The primary infection means we have a lymphadenopathy, lymphangitis, fatty opacity in the periphery. That means this is the initial response on exposure to the TB bacillus. The TB bacillus, as I told you, will be taken up by the dendritic cells and also the alveolar macrophages. They multiply inside. They are released into the stream. Again, they activate more number of macrophages, and then they spread to the local lymph nodes. There's lymphangitis, lymph node enlargement, and there is a T cell activation. So they all produce what is called the lymphadenopathy, lymphangitis, and a patch of consolidation. So we have a patchy consolidation in the right mid zone or the right lower zone. Then we have lymphadenopathy, and this is what is called the wrong focus or the primary complex. Next slide, please. And so these cases, it may heal by themselves or it can spread and form a disseminated TB. With involved some, in the case of children, they can develop tubercular meningitis, a disseminated TB, and otherwise it may have a disseminated spread and it are contained locally, and it may remain in a dormant state, and which can get activated at a later stage. So we have what is called the Walgren's timetable of the development of various types of tuberculosis. The first we have primary complex, then we have CMI developing by about 8 weeks, then by about 6 to 1 year's time, you develop pleural effusion, you develop disseminated TB, and also develop tubercular meningitis. Then, of course, between 3 to 5, then you may develop, you know, the GI tuberculosis, the renal tuberculosis, or bone tuberculosis. So, for them to develop it more time, and disseminated disease you can develop at the early stage of the disease. So this is what is called the Walgren's timetable. Now, when you look at the post-primary TB, when you do an X-ray, you may find that they have a focal heterogeneous opacity. We have areas of consolidation. We have areas of fibrosis. Fibronodal opacities will be there. There will be areas of necrosis, and a cavity formation will be there. So there is volume loss. Distribution is typically in the upper part of the lung, that is the apical and the fossa segment of the polyps, and also the middle lobe, and in the apical segment or the superior segment of the lower lobe. And then basically these areas are more affected because of the local immunity, and also because of the ventilation, and also because of the spread of the TB bacillus more to these areas, and also because of the lymphatic distribution. So all these factors are responsible for development of tuberculosis in certain specific anatomical sites of the lung. Next slide, please. Now, the findings are fibrosis, cavitation, infiltration, consolidation. Sometimes you can have a solitary pulmonary nodule, which we call the tuberculomas, and they may be sometimes difficult to differentiate from the solitary pulmonary nodule due to malignancy. Please remember that. Next slide, please. Next slide, please. So the latent TB, in India, we don't treat latent TB unless they have associated immunosuppressive conditions. So classically, you give 6 months to 9 months of isoniazid, and then rifampicin for 3 to 4 months, rifampicin isoniazid for 3 to 4 months, rifampicin alone for 3 to 4 months, then 3 months weekly rifampicin and isoniazid, 3 months weekly rifampicin isoniazid. So they have done various studies. They found that the hepatotoxicity is much higher if you give isoniazid for the long duration. And when you give the combination therapy for the short duration, the development of tuberculosis incidence comes down, or the results are somewhat comparable to that of the isoniazid, which is given for, say, 9 months. And of course, the hepatotoxicity is also much less. So that means you can effectively treat LTB by short course combination therapy of isoniazid and rifampicin, rifampicin and isoniazid at given for 3 months weekly. Next slide, please. Next slide, please. So this is what it says. INS rifampicin. Rifampicin was at least as effective as 9 months of isoniazid alone. INS rifampicin TB rate was approximately half that of the 9. That means it's much more effective, shorter duration, compliance is better, and then the completion was 82% versus 69% those who use INS for 9 months. And INS rifampicin is very safe compared to 9H. So adverse events are much less, hepatotoxicity is much less, and no significant risk of associated of drug resistance. So this is the outcome of using the combination therapy, INS and rifampicin weekly for 3 months. Next slide, please. Now, treatment of pulmonary tuberculosis, new patients with pulmonary TB should receive a regime consisting 6 months of rifampicin. Rifampicin is the most effective bactericidal drug which has got action both on intercellular and extracellular organisms. It is effective against the different types of mycobacteria, which may be slowly multiplying, rapidly multiplying, or for having intermittent multiplication mechanisms, or intermittently they are multiplying. Okay, so we have 4 types of mycobacteria. Some are rapidly multiplying, some are slowly multiplying, some are actually multiplying intermittently, some remain in a dormant state inside the macrophages. And those which remain inside the macrophage is dormant state of the persistence. And there is no drug which is effective against this dormant bacilli. Rifampicin is the one which actually is very effective in reducing the infection because it destroys the growing mycobacteria, multiplying mycobacteria. So the sputum load of mycobacteria dramatically decreases when you give rifampicin and INH. INH is also bactericidal drug, which also acts similar to that of the rifampicin on different populations of mycobacteria. It does not have activity in the dormant bacilli. And then we have other drugs like pyrazinamide, which also acts in the intracellular acidic pH. And it may have a better effect on these persisters or dormant bacillus compared to the mycobacteria due to rifampicin and INS. And then we use ethambutol, which is a bacteriostatic drug, which again has got action on the mycobacteria. So they use these powerful antimicrobacterial drugs, which act at the various levels, various types of mycobacterial population. And when you give this treatment, and when you diagnose a case early and you institute this treatment, then the outcome is excellent. So normally we give what is called the initial phase. And then we have a consolidation phase or maintenance phase. The initial phase consists of 2 months of treatment, daily treatment of INH, rifampicin, pyrazinamide, and ethambutol. You all know the dosage of INH. It is 300 milligram or 5 milligram per kg body weight. That is a drug which is used in case of children. Hello. So, which is this one. So, patient where permitted should have received these drugs as far as possible. And as I told you, that these in the initial phase we use 2-EHRZ. The 4 drugs are used, and INH in the dosage of 5 milligram per kg body weight, rifampicin 10 milligram per kg body weight, and pyrazinamide, as you know, can be used is 1.5 to 2 grams, and ethambutol again we use from 800 milligram to 1.2 milligram, 1.2 gram of ethambutol, 800 milligram to 1.2 gram of ethambutol is used. And we have various, what is called you know, we don't have to give the drugs. We have combi packs are also available. And then we have also tablets which has got the rifampicin, INH, and pyrazinamide ethambutol all together. So we have, so which has in fact helped the complaints. The fixed dose combination FDC tablets is recommended over a separate drug formulation in treating patients. So instead of giving each drug separately, we have a fixed dose combination. So each tablet has got a fixed dose of INH, rifampicin, pyrazinamide, and ethambutol. And we have to give 3 or 4 tablets. It reduces the tablet burden, pill burden, and also the compliance is better. And this is recommended by WHO because it has a better bioavailability as well. So in new pulmonary TB patients treated with this regime containing rifampicin throughout the treatment, so if the sputum smear is found positive on the completion of intensive phase, the extension of the intensive phase is not recommended. So this is the WHO guidelines. Next slide, please. You send for culture sensitivity, you continue the treatment. So some of these cases, they don't respond to treatment. So they have got a drug resistant TB. Now, it is basically because we don't have a proper, you know, treatment programs. They're not following the guidelines. There is a poor training. So the DARs are not properly implemented. So there's a lack of treatment monitoring. And there could be inadequate supply of drugs. poor quality of drugs. And the patient may not be taking the medicine properly. Inadequate adherence to the treatment, adverse effect and malabsorption, social barriers, lack of money, substance abuse. So all these things. That means there could be poor compliance on the patient. There could be inadequate drug supply. Are the standard programs are not implemented. So, so there are multiple inadequate treatment, inappropriate treatment, poor compliance. All these factors are responsible for the generation of MDR-TB. Next slide, please. So we have different types of drug-resistant tuberculosis. MDR-TB means we have isoniazid deformation resistance. Then monoresistant tuberculosis means they are resistant to ionate, they are resistant to ethambutol, pyrazinamide, etc. Then we have polydrug resistant means they are resistant to multiple, but they are not MDR-TB. Then we have XDR-TB, that means they have MDR-TB, multi-drug resistant tuberculosis, isoniazid rifampicin, and they are resistant to fluoroquinolones, like ciprofloxacin. Then we have fluoroquinolones, that is levofloxacin, moxifloxacin, and then they're also resistant to what is called the kanamycin, amikacin, or capromycin. So when they're resistant to one of the injectable drugs, and they're also resistant to fluoroquinolones, they're resistant to rifampicin isoniazid, that is called the XDR-TB. So the first line drugs, we have ionized rifampicin, pyrazinamide, ethambutol. Injectable drugs, we have streptomycin, kanamycin, amikacin, and capromycin. Fluoroquinolones, we have ciprofloxacin, ofloxacin, levofloxacin, moxifloxacin, and gatifloxacin. Second line oral agent, we have ethanamide, parathanamide, then paramynosalicylic acid, then cyclosporin. We have third line agents, non-routinely recommended, efficacy unknown. This is amoxicillin, clavulanic acid augmented, clarithromycin, clofazimine, linezolid. So we have different groups of drugs which are available. Next slide, please. Next slide. So WHO has categorized, previous slide, please. Five categories. We have isoniazid resistant, we have rifampicin resistant, then MDR-TB, that is pre-XDR-TB, resistant to rifampicin, and any fluoroquinolones. That is pre-XDR-TB, and any fluoroquinolones. Then we have XDR-TB, which I've already told you, resistant to rifampicin, fluoroquinolones, and one of the injectable drugs, and also ionized. So, and then, so please understand that in the latest classification, they have added, instead of injectable drugs, they have used resistant to rifampicin, fluoroquinolones, and one of the drugs like betaquilin and linezolid. So there is also another definition of XDR-TB. Earlier, as I told you, XDR-TB means they are the one who are resistant to rifampicin ionate, fluoroquinolones in injectable drugs, and in the new XDR-TB nomenclature, we have resistant to rifampicin plus fluoroquinolones and one of the drugs like betaquilin and linezolid. Next slide, please. Next slide, please. So we have to build up a regime, use 5 drugs to which isolate is susceptible, preferably drugs which are not used previously, and choice of drugs, capacity to monitor adverse effects, comorbidities. So we have to choose drugs which are bactericidal. More than 5 drugs should be used. And then in case of children contacting MDR-TB, the source case isolate, then drug sensitivity test should be used if an isolate is not obtained from the child. When you're not able to isolate the organism, then you have to find out the source and try to isolate the organism and do drug sensitivity test, accordingly formulate a regime. Next slide, please. So, and this XDR-TB should be actually treated by experts. in a specialized center. Next slide, please. So choose one of the later generation fluoroquinolones, levofloxacin, moxifloxacin. Then step 2, you choose both of these prioritized drugs like bedaquiline and linezolid, because these are the two drugs which have made a difference in the outcome of the XDR-TB. Choose both these prioritized drugs, step 3, that is clofazimine and the cycloserine. If a regime cannot be assembled with 5 drugs and isolation is susceptible to one of the injectables, in such cases, use amikacin and streptomycin, one of them. And in the step Y, if needed, a oral agent preferred or injectable agent. Instead of going for step 4, use one of these drugs, delamanid, pyrazinamide, and ethambutol. And when you have a limited options, you cannot assemble a regime 5 objective effective drugs, consider use of one of the drugs, ethanamide, proethanamide, imipenem, celastin, clavulanate, meropenem. Then you use para-aminosalicylic acid, high dose isoniazid. And as per the latest recommendation, we don't normally recommend captomycin, kanamycin, augmentin, and then azithromycin and clarithromycin. So therefore, the message is loud and clear. When there is a drug-resistant TB, in such cases, we have to do a drug sensitivity testing. Then we have to use 5 latest generation drugs, those which have not been used, and we have to select the drugs from levofloxacin, moxifloxacin, bedaquiline, linezolid, clofazimine, cycloserine. Then, where we have no choice, but we have to do injectable, then we have to do amikacin and streptomycin. And if you don't want to use injectable, then in such cases you use delamanate, pyrazinamide. And then even the drug sensitivity test says that, you see, you are not able to produce 5 drugs. In such cases, then we have to, as a 6th step, we may have to go for ethanamide, proethanamide, imipenem, celastin, and meropenem, high doses of INH, and para-aminosalicylic acid. Next slide, please. So, bedaquiline, we all know, is the diaroquinolone, 400 milligram for 2 weeks, 200 milligram thrice weekly for 22 weeks. Patients should not be HIV, children, pregnant, and those who are more than 65 years old. So, in such cases, the drug should not be given. If there's a pregnancy, you give 2 HRE plus 7 HR. In lapse cases, we give 3 months of EHRZ plus one of the injectable, and then 5 months of HRE, that is isoniazid, rifampicin, ethambutol. In INH resistant cases, you give 9 months of rifampicin, pyrazinamide, ethanamide, and then those who are resistant to rifampicin and pyrazinamide, you give 2 HRE plus 7 HR. So various regimes have been formulated. Please understand. But what is important is that you should have a sufficient duration of regime, and then you should have bactericidal drugs, and the regime should be proper depending upon whether it is a single drug resistant, whether it is resistant to the multiple drugs, or whether you have a drug MDR-TB or you have XDR-TB. I mean, so accordingly we formulate. When there is a monoresistance, there is no issue. Here, you give the treatment for 9 months and you increase the intensive phase by 1 month. Okay. So, next slide, please. Next slide. So, the last part is previous slide. The last part is prevention. So, BCG, no doubt, has made a difference in terms of preventing very serious disease like disseminated tuberculosis, meningitis. But BCG does not offer protection from development of other forms of tuberculosis. And then infants with HIV status not known born to HIV positive mothers should not receive BCG. In HIV cases with exposure to infected TB, irrespective skin test, INS prophylaxis should be given. So, INS prophylaxis, as I told you, we have various drugs which are available, 4 months of rifampicin, 2 months of RS, rifampicin, pyrazinamide, 3 months of rifampicin INH, then we have INH and rifampicin weekly, then 9 months of isoniazid. I've already told you. So, uh, we have to select drugs as per the availability, and so the results are very good if you use short course rifampicin and INH weekly for 3 months. Next slide, please. So earlier we were talking of TB control, and today we are talking of TB elimination. So what was this? The turning point. We had an epidemic in 90s, the drug-resistant tuberculosis, and HIV. It made tuberculosis a global problem and a most dangerous disease. And the time bomb is about to explode. So that was the critical situation. And thereafter, HIV detection, diagnosis, as well as treatment became possible. And similarly, we could also treat those patients who had HIV and tuberculosis effectively. So the HIV TB deaths could be reduced and HIV epidemic could be contained. So as a result of which, there was a stabilization in the prevalence as well as incidence of tuberculosis. So as a result, in 2013 onwards, there was a declining trend in the incidence of tuberculosis. Therefore, as the Millennium uh, WHO recommendation is a Millennium goal, so by 2030 we should be able to end TB. What is NTB? That means we have to reduce the incidence of tuberculosis active cases by 90%. And then we should actually treat these cases, uh, from the government sources, all especially the poor people, so that it should not be an economic burden on them. So that is the end TB. End TB means you should be able to detect and diagnose as well as treat all those active tuberculosis, and their incidence should decrease by 90%. 90%. And the treatment should be universal and should be affordable. And there should not be any burden on the weaker section of the society. So, with this idea, it has been found that if we actually accelerate the decline of the TB prevalence and incidence, then we shall be able to achieve end TB by 2025 to 30. So if you look at this particular slide, then this decline should be from 2%, the decline should be about 10%. Then it should decline by 5% after 2030. So the average decline from 2% should increase up to 10%. That means we have to detect more number of cases. We have to put them into the scheme. They have to be treated effectively. the new infection should be reduced. The annual incidence should decline by 10%. And if that is possible, then we can achieve end TB by 2030. And this HIV, so this COVID-19 infection, in fact, it has halted the decline in the annual incidence of the TB, and that is a setback. Even then, there have been great efforts to achieve by 2030, and in Indian case by 2025. Whether it is possible or not is only time can tell us. But the fact of the matter is that the TB has to be eradicated. Eradication of TB means by 2050 or so, we should have one case per 1 million population. Next slide, please. So, less than 100 cases per million, the current TB burden of 2012. So, by 2035, it should become 10 cases per million. And by 2050, it should be less than one case per million. Please understand what I say. And today, we have less than 100 cases per million. That means it is around 500 to 600 cases per 1 lakh population. Now, at present, we have by pre-elimination by 2035. So here it should be less than 10 cases per million. And by 2050, it should be less than one case per million. Is it possible? With 40% of latent tuberculosis, which can explode like anything in a HIV setting or the immunocompromised status. Next slide, please. Next slide. So this is just a, so the three, so that means we have to detect active TB cases. We have to treat them effectively. We have to detect latent TB. And then we have to treat them effectively. And especially those who are immunocompromised. So we have to eliminate both latent as well as active TB. And if you can do that, then the annual incidence should come less than 1 per million population. That is total elimination of TB from the globe. Just like we have eradicated smallpox, it is eminently possible to eradicate TB, provided there are no further epidemics like COVID-19 and other epidemics coming in. And our healthcare system has become universal. And we are able to diagnose disease early in the stage and detect and treat them. And we can eliminate, we can also treat latent TB. And we can effectively manage high susceptible groups by effective treatment so that the body immune response is well maintained. So we have to have a concerted, comprehensive approach. And when these approaches become a reality, then such a goal can be realized. There is a long way to go, many miles to go before we sleep. Next slide, please. So, with three major weapons in the eradication: chemotherapy, vaccination, and chemoprophylaxis. In the vaccine front, somehow BCG has failed, and we do not have an effective vaccine today which can prevent the spread of infection, or which can prevent the development of disease and a person who is infected. So when we have an effective vaccination, something like a pneumococcal vaccine or the influenza vaccine, then we have effective chemotherapy. The most problematic area is drug-resistant, total drug-resistant tuberculosis. Of late, we have only two effective drugs, delamanid and bedaquiline and some of the linezolid, then moxifloxacin. But then we have not come out with a very powerful antimicrobacterial drug which affects all the growing bacteria, intercellular, extracellular, latent, and intermittently multiplying bacteria. And few doses sufficient to eliminate them, just like when we treat a bacterial infection. So 1 week or 2 weeks of treatment is able to actually eliminate the bacteria. But in case of tuberculosis, we have to give for a longer duration. So if you can find out a drug which can act in a short time, which hits hard, which hits fast, as well as of a shorter duration, then TB elimination can be done without much of a hiccup. Next slide, please. So, ladies and gentlemen, I've tried to give you a bird's eye view of the treatment of tuberculosis, specifically highlighting the about the management of tuberculosis, highlighting how, what are the different types of mycobacteria, how we get the infection, and then what is the pathogenesis, and then what is the pathophysiology, the pathology, and what are the manifestations, clinically as well as radiologically, and then how do you diagnose TB by sputum examination, by the classical methods, by fluorescent technology, then also by molecular techniques, especially with emphasis on expert TB assays, which actually detects the reform% resistance. Then we have TrueNut, which is developed by the Goa laboratory, which again detects the Mycobacterium tuberculosis, including resistant ones. Then we have liquid cultures, MGIT, and then you do the molecular studies on that by using the genetic probes to identify resistance to the first line as well as second line drugs. Early diagnosis could be managed, could be early diagnosis could be made, and then of course I told you what are the different types of TB, what is latent TB. Latent TB is one they don't have acute disease, but they have immunological response to the TB antigens, which can be detected by EXA test or by Martooth's test. Then I told you what is active TB. That means they have clinical features, radiological features, and also the sputum will be positive. And then I also mentioned about the drug sensitive as well as drug resistant TB. I also mentioned what is primary TB and relapse TB and active post primary TB. Then I also emphasized on the various drugs which are available, various groups of drugs which are available. Then I emphasized on how to manage the drug resistant TB, how to manage the drug sensitivity TB, and then how to formulate the various the chemotherapeutic drug regimes. And even with all this drug regime, uh, the success rate is around 60% if a person has got MDR TB. So the most important lesson that you have to uh, get from this presentation is that TB has to be detected early and it has to be treated before they develop drug resistance. And the drug resistance, as I told you, is because of inadequate treatment, inappropriate treatment, lack of availability of drugs, and uh, and also the individual factors which may be there. There's a poor drug metabolism or absorption. So all these things will contribute to the development of drug resistance. And drug resistant tuberculosis requires expert. We have good laboratory facilities, and we have to the latest drug should be available, and one should monitor for adverse reactions, and then the treatment has to be for the longer duration. And there have been various regimes which have come into place. I do not want to go into all those details, but if you have any questions on these latest regimes also, I shall be eager to answer them. So I have finished my presentation. Thank you so much. If you have any questions, kindly shoot back to me. I shall be eager to answer them. Thank you so much.
Hello. Hello. Sir, some questions are there. Some questions are there. Just a minute. So the first question is, hello, hello, yes, sir. The first question is, which comorbidity has contributed to the emergence and spread of drug-resistant pulmonary tuberculosis?
Hello. Hello.
Hello, 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 sir. I have posted the first question in the chat.
Hello. 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 You see, I'm not able to. Yeah. Yeah. Hello. You see, the problem is I finished my presentation, but I have not heard anything from the opposite side. So I do
Hello,
not know whether my presentation is over, any questions, because I do not know how to actually answer these questions because there is no audio communication. Yeah, yeah, that's fine. Is my presentation? Okay, very nice, very nice. But what I suggest now, that why can't you send the latest version of the Zoom, which is actually as per your requirements, to me? Okay, okay. I will do that. Anyhow, I think the session is over now. Okay, thank you so much. Okay, fine. Okay, okay. Good night.
Hello. Hello, sir. Am I audible?